So, good evening, everyone. On behalf of Swati Health Private Limited, I welcome you all to the session of Swati Health Bridge, Clinical Conversations that Matter. So, today's session focuses on intravesical Pentosan Polysulfate installation, exploring its expanding indications and real-world outcomes. I now invite our co-host, Dr. Dheera Samdariya, Urogynecologist from Jaslok Hospital, Mumbai, to introduce our speaker and lead the discussion. Over to you, Dr. Dheera.
Thank you, Ashwini. Good evening, everyone. We welcome all of you who have joined us today for this very interesting discussion, Pentosan Polysulfate Installation in Bladder Pain Syndrome. At the outset, I would like to thank Swati Spentos for organizing this webinar and bringing us together on this platform of Swati Health Bridge, where we can all come together, learn and grow, and ultimately treat and help our patients better, which is the goal I know of each of us who have joined here today. I also thank Dr. Rajesh Taneja, sir, for joining us today and sharing with us his experience and expertise. Thank you, sir. We welcome you.
Thank you. Thank you very much.
Thank you, sir. Before we begin this session, sorry, sir, did I interrupt you?
No, not at all. Not at all.
Before we begin this session, let us take a look and understand as to why bladder pain syndrome. How would this 1 hour help our patients better? How far have we come in managing this complex heterogeneous condition? Once again, for all those who have joined us, I welcome you. I'm Dr. Dheera Samdariya. I'm a urogynecologist from Mumbai. Why did I choose urogynecology? Well, to be honest, while in medical school, I looked at the pelvic floor anatomy and its functioning more as a threat to my passing in my examinations. But while doing my OBGYN residency, it was more like a puzzle to me, the pieces of which I tried to put together and integrate the information for better understanding. Now, having entered clinical practice, I go back a little, not as a threat anymore though, but now it's a mystery to me, a challenge to find the clues and solutions in order to help the patients overcome their problems. And bladder pain syndrome, this falls into this very clinical entity. A mystery remains a challenge to me, and I know many of my colleagues as well. And the most rewarding in this, I think, is the feeling of satisfaction when the patient is relieved to find a diagnosis and then how we can further help them navigate through it. I had recently attended the 10th annual conference of GIBS, which is the Global Interstitial Cystitis Bladder Pain Society, which was held in Mumbai in August 2025. Since then, I must say there has been an improvement in my approach to these patients. So I thank you for organizing the conference. And it was out there where I met the team of Swati Spentos and learned of the new treatment approach that they had of Pentosan Polysulfate Instill in bladder pain syndrome. I did happen to discuss with them as to why did Swati Spentos choose to direct their efforts in building treatment options for bladder pain syndrome. Well, they were of the opinion that they saw the burden of the disease in the society, the impact the disease has on life, the lack of awareness that is there about this condition, and hence they felt the need to address it and give it wider, better treatment options in the category of patients that would benefit from it. And to throw light on this very subject of bladder pain syndrome and the Pentosan Polysulfate Instill, well, who better than Dr. Rajesh Taneja sir himself? So once again, thank you for joining us. Dr. Rajesh Taneja, sir, is a senior consultant and advisor, Department of Urology and Robotic Surgery at Indraprastha Apollo Hospitals, New Delhi. Sir has completed his MS General Surgery from Maulana Azad Medical College, New Delhi, and MCH Urology from the esteemed AIMS, New Delhi. He is one of the very few urologists performing the state-of-art robotic urological procedures since 2012. He is also the founder chairman of Global Interstitial Cystitis Bladder Pain Society, which was founded in 2015. He has chaired and hosted the prestigious European Society for Study of Interstitial Cystitis, the annual meeting in New Delhi, November 2016. He has been performing the holmium laser endourological procedures for almost 2 decades now, and he is a leading holmium laser surgeon in the country. He has been a mentor for the holmium laser programs in the country and across and abroad as well. He has conducted several workshops and performed live demonstrations of the holmium laser procedures in national as well as international conferences. He's also a Limca Book of Records holder for removing the largest kidney tumor in the world, which is 7.5 kgs. This is a large one. he also has 35 original publications, mostly in international journals, and he has also authored 3 books. Sir, we welcome you once again. Before we begin your talk and your session on Pentosan Polysulfate Instill, so could I ask you a couple of questions?
Yes, of course. Thank you very much, Dheera, for this kind introduction. Go ahead.
Yeah.
What do you want to ask?
Sir, why bladder pain syndrome? What led you to dive deeper into this subject and conduct the research and trials and provide better treatment options?
So as you rightly mentioned, I got my training from the esteemed All India Institute of Medical Sciences, and I started practicing in New Delhi. And I felt bad if any of my patients didn't get better. Who else could I refer her or him to? Because, this was the best place. And if I couldn't do it, who else would do it? So I looked at it, retrospected it, and I realized that why people are not able to look at it is because when I was getting trained at All India Institute of Medical Sciences, I was taught that this does not exist in our part of the world, at least. So I was taught that interstitial cystitis does not exist in India. So that was as late as 1991, 92. But when I started my practice in 1995, I realized that there were patients who would fit into this definition. And we were all struggling. There was no definition as such, but in Campbell's Urology, there was a single small chapter that we read, and that also had confused a lot. And we were not sure. And I would not rest at peace in that evening after I returned from work if I had seen a patient who was in pain, whom I knew was suffering, but I couldn't help her or him. Being a urologist, it was a urological problem, and I took it on myself to make sure that I should be capable enough of dealing with it. If I'm not, then who else would try to do that? So that is where I got stuck, engaged with the interstitial cystitis bladder pain syndrome.
Wow, thank you. Thank you, sir, for your dedication to it. So, if I may ask, was there any particular patient that stood out to you or still stands out to you related to bladder pain syndrome, male or female, that had an impact in you diving deeper into this subject?
Yes, of course. That is where I was trying to tell you that I was in my clinic in New Delhi, and I had just started my practice, and I had enough time at that time. So I got this patient, a lady in her 50s and her husband, and they were carrying a huge file of investigations and papers, very nicely documented. And this gentleman came and sat in front of me and put the file on the table and said, "Look, if you can treat her, you treat her. If not, I'm not taking her home. So either she'll poison herself or I'll give poison to her." So that was a moving moment for me, really. I don't know why they said that to me. I'm sure they would have seen tens of doctors before me, but why did they choose to use that word, that sentence to me? And I really got moved, and I said, I have to find something for this lady. Otherwise, he would throw her out of his house. And that really made the impact that was needed for me to work towards this disease.
So, I think we have all heard that chronic bladder pain can be such a debilitating disease, but I think having seen a patient go through it, you can even see it practically. Thank you. So, do you feel that we as a fraternity have come a long way in the treatment of this condition? As you have witnessed the evolution of the treatment options in this disease, do you feel that yes, we are getting there, we are better, or is it still a long road ahead?
No, it is much better than what we started almost 30 years ago, because when I started it was 1995 and today is 2025. So 3 decades of work. So when we started, we were not sure what this disease was. There were various definitions and there were various confusing situations where people would call it this. I know there are so many people even today who do not, who deny the existence of interstitial cystitis in the world. And then we now have clear-cut definitions. We know how to diagnose these patients. Earlier, it used to be a waste paper basket diagnosis that wherever you cannot do anything, you label it as IC. And we saw those papers coming to me. And now we at least have the diagnosis. Not only do we know how to diagnose this, we also know how to phenotype it. So if you look at the literature 50 years ago, the success rate was 30%, 40%. Why was the success rate 40% of a particular treatment modality, maybe amitriptyline or maybe hydroxyzine? It was because it would have some effect on some patients. But we then realized that if we could segregate those groups of patients where this would work, so then that would perhaps work 80% in that group or 90% in that group. So that is how we have not only defined the disease, we have now today, we have phenotyped it, we have classified it, and then we have linked the treatment to each group. And that seems to be working well. So we have come a long way. We still are, there is a long way to go still because we are now looking at AI, we are looking at the biomarkers. And for example, there was a time when we were not able to diagnose pregnancy. So we used to get as an undergraduate, I used to get a long question that if a lady has missed periods, how would you proceed? So we would say, okay, these are the changes, physiological changes that I would look for to make a diagnosis of pregnancy. Today, you have a card test. You just have to put a drop of urine and the diagnosis is there in front of you. So I wish we have a card test to come where while the patient is waiting for me to be seen in my office, she just puts a drop of urine in that card and she has a diagnosis before she comes to me. So I'm sure that will happen. Maybe it takes some more time, some few more years, but I'm sure we are all working at it. The technology is at it, and maybe we'll find something.
Yes, so I did happen to read the article that you have published on clinical phenotyping and the respective treatment modality based on their phenotype. It definitely allows us some delineation, and instead of giving blanket therapy, we can at least give targeted therapy. Yes,
Yeah.
thank you. Yes. So was this also your thought process on co-founding Gibbs? So many congratulations on the 10th anniversary of Gibbs Society. It said that a journey of 1,000 miles begins with a single step. Did you have a certain thought process or a goal when you had co-founded Gibbs?
Yes. So this was very important. So I was associated with the European Society of Study of Interstitial Societies, ESIC, and I used to attend their meetings annually, and we really used to share, and I learned a lot in those meetings. We were all evolving, so I was also evolving. And then I came back and I realized that we need to spread this knowledge, whatever I had achieved. So in 2014, I published a book on IC, interstitial cystitis. It's a small book, but then I wrote it because I thought that whatever is my concept, it will die with me if I don't pen it. So that was the reason of writing that book. Similarly, in 2015, I I was honored by the ESIC, European Society, to host a ESIC meeting in India. That was a huge recognition of my work because European Society being hosted outside Europe was a great thing. And that too in India was really a big thing at that time. And so I needed to know how many people were interested in interstitial cystitis because we were going to have a mega event in Delhi, and I wanted to collect people, doctors who would be interested so that they are benefited by the European faculty who are going to come to us. And that is how we started this group. And that started off with a small group in Mumbai with Dr. Sanjay Pandey, Dr. Shivam, Dr. Apul Goel, and Dr. Ranjana, and Dr. Amita Jain, and Dr. Navita Purohit. So 8 of us, we started, we had a brainstorming session, and then we wrote about what should be the concept, what was the definition, what was the clarity of definition at that time. And that's how it started.
Thank you, sir. Thank you to you and your entire team for bringing this together. It's definitely helped me and my colleagues. I have even visited the GIBS website and gone through the 8 modules of learning the disease process. So thank you, sir, for putting it out there for all of us. This may be like a little divergent question, but in the field of urology, is there any other subject which interests you as much as bladder pain syndrome, interstitial cystitis?
Yes, so I I am a primarily robotic oncosurgeon when I'm sitting in at Apollo Hospital. So I do robotic surgery for cancers of prostate. And we started this in 2012. I started doing robotic. That time there was a handful of Indian urologists who would be doing robotic surgery. Now, of course, almost 15 years later, so many other centers have come up with a huge number of robots in India. But at that time it wasn't. So the number of cases that we have been doing and the way we evolved, and I love those robotic surgeries. We have been going stepwise. So that is my passion again, to achieve the best results. So our results are one of the best, and they are comparable to the best in the world. So that is the primary urology that I do. So I always say that is urology. So I do holmium laser enucleations, robotic surgery, stone surgery, and this ICBPS has a special slot. It is like a passion in addition to whatever I do in urology.
That's great. I remember, so you did mention once that a surgeon is who combines science and art together. He's an artist with the backing of science.
Yeah.
So the final question: teamwork or one-man army? Which side would you lean towards?
Of course, it's teamwork. You cannot do anything. You even whatever I'm doing as a in ICBPS, if you look at all the publications that have come up, so I give one portion to my resident, and that resident takes care of that, and he writes a thesis or she writes a thesis. And that is how we compile, we talk, we discuss, and then we need the pathologist, we need the gynecologist, because I send all my lady patients to the gynecologist who's sitting next to me, that is Dr. Ranjana Sharma, fortunately. So she gives me an overall, and she writes beautifully the way a gynecologist should examine a patient in the exam, so to pass an exam. So that is how I have everything as per book with me. So all information is there. And then that is how we start with. So history and examination. Examination is incomplete without a detailed gynecological examination by a lady.
Thank you, sir. As you mentioned, that teamwork is the way forward. So, could you give one tip for aspiring urologists, gynecologists, urogynecologists, physiotherapists, pain specialists who come across these patients?
Yeah, work together, learn from each other. You tell them your view, listen to their view. For example, when I send it to a physiotherapist, and she calls me back, I listen to her. It's not that I'm a urologist, so I should not be listening to a physiotherapist. No, we work together and we have equal amount of responsibility when it comes to treating a patient like ICBPS. So that is where I would say that you must uh, regard each member of your group. For example, the one that we are doing now is an overall tacrolimus for Hunner's lesions. So my previous resident, who is a faculty now, he told me, sir, we have phenotype. You are doing very well. There's one phenotype who keeps coming back again and again, and that is Hunner's lesion. You must think of doing something for it. And I listened to him and I said, okay, now that you've told me, I'll think about it. And we came up with the idea of tacrolimus oral. So that is how you listen to each person in the group and in the team.
Thank you, sir. Thank you for your words of wisdom. Now, without further ado, sir, I hand it over to you for your session on Pentosan Polysulfate Instill. Thank you, sir.
Yeah. Thank you very much. Let me share this and maybe I will. Um, I hope you can see my screen, Dheera. Uh, Is my screen visible?
Yes, sir.
Okay.
Yes.
Okay. Thank you very much, Dheera, for giving me this opportunity and introducing the subject so nicely. I'm sure people in the audience would be happy to start looking at what we are going to talk. And thank you, Swati Spentos, for this wonderful opportunity and this initiative of Swati Health Bridge. And I'm sure this is the first one, and there are many more to come. So I'm going to talk about intravesical pentosan polysulfate Comfora Instill. But the point is that we need to first know when to use it. So I will start with this thing, and that is a case from my clinic, which is a 46-year-old lady who had been having frequency every 30 minutes, which means if it is 30 minutes, that means that almost 60 times of, or maybe 50 times in a 24-hour period, whether it was day or night, with pain in suprapubic region and vulva, and had some relief on passing urine. And she was treated as a recurrent urinary infection without any microscopic pyuria. Now, I'm sorry, I'm trying to, yeah. So when I looked at it, she had a general condition was run down. She had suprapubic tenderness. She was depressed, anxious, and was looking at me whether I would be able to be of any help to her or not. But somebody had sent her to me, and we investigated. We found that there were no pus cells in the urine, and culture was sterile. And the ultrasound did showed that there was a full bladder volume of 85 cc. The normal full bladder volume is almost 500 cc, but in this patient, it was just 85 cc's, and the residual urine was 25 cc. So when we look at the definition of Gibbs, it says that it is either pain or discomfort in the lower abdomen or urogenital area with of more than 3 months duration, which is usually worse on full bladder, along with one or more urinary tract irritative symptoms like frequency, urgency, and nocturia, with or without standard stigmata on cystoscopy, provided another discernible pathology which is likely to cause these symptoms have been excluded. So this was the Gibbs definition we wrote in 2017, and it holds even true today. The distribution of pain could be lower abdomen, perineum, vulva. That is why it is called lower abdominal or genital area, including the anal canal or the anus. So this is important that the pain could be any of these places. And pain is essential for diagnosis of ICBPS. I see that there are certain groups who have been confused and have been confusing by saying with or without pain. No, there is no bladder pain syndrome without pain. So remember, pain is the primary uh, component of this clinical diagnosis. And in 1978, the Campbell's Urology, which is the Bible of urology for the urology residents and the consultants, and in 1978, it was written that it is just an end stage of a bladder that has been made irritable by emotional disturbance, a pathway for discharge of unconscious hatreds in women. So I think that was very harsh on women and the patients, but that was the science as we know today that at that moment was. So, but the present day understanding is that it is a chronic bladder disease, a combination of heterogeneous clinical entities. It is heterogeneous, that is why one treatment doesn't treat all. And the pathology ranges from intense transmural inflammation with or without ulceration of the urothelium to something that is happening elsewhere. For example, there could be a pelvic floor spasm, or there could be a neuropathic pain which will manifest as bladder pain with urgency and frequency. So there could be a horde of diseases which could confuse, but one has to spend adequate time to take history on whether it was really any one of them, which is the simple urinary infection, PID, infective vestibulitis, stone disease, tuberculosis, which is common in India, and although not as common as it used to be 50 years ago, and endometriosis, infertility, and of course, neurogenic causes. There would be sometimes trauma which has been forgotten because the only organ that was being affected was either the perineum or the bladder, and some lower limb symptoms which people would discount. And of course, multiple sclerosis is one of those diseases where you have skip lesions, and that can present in many ways. And one of them could be this. So the term urgency is important because urgency could be sensory as it happens in ICBPS. So when you talk to the patient, that the patient says that I have to go to washroom very often and I cannot hold on. That is the urgent desire to pass urine. Then a simple question is, what would happen suppose there is no washroom around or you are not allowed to go? And if the person says that she will have intense pain in the lower abdomen, then this means this is a sensory urgency. That means it is the sensation which makes it urgent, and this is the bladder pain syndrome. Whereas in overactive bladder, which is very closely seen in these patients, in some patients with similar symptoms, but then there is absence of pain, and the person says that she fears of leakage of urine. So she would say that nothing else would happen, but I am so uncomfortable because I feel that I would leak urine. So that is the motor urgency. So one has to differentiate the urgency of the bladder pain syndrome and that of the overactive bladder. So the clinching question is, are you scared of leaking of urine or are you scared of pain? The other question is, when you wake up from sleep, do you wake up with a full bladder sensation or you wake up with pain in the bladder? So patients with ICBPS will tell you that they wake up with pain in the bladder. So they are scared to go off to sleep because if they go off to sleep, then it can cause pain. And that is the pain that wakes up. So if you are still not very clear about the diagnosis, then what you can do is, because pain in the lower abdomen could be coming from bladder, from uterus, or from colon. So if you put lignocaine inside the bladder and the pain disappears, then obviously this is coming from the bladder. So this is one of the ways, a very simple way in your office. You can put a small dose of lignocaine into the bladder, and if the pain disappears within a matter of minutes, then obviously the pain was coming from the bladder. So that is why it is important that we stick to our definition of gifts that I just mentioned. And once we have patients in whom we suspect that there could be ICBPS, we should what we should do is we should tick these boxes. There should be a detailed clinical history, physical examination, frequency volume chart. Frequency volume chart means that obviously you should know how many times the patient is passing urine. For example, during the day, the patient passes 20, 25 times, but when she sleeps off, then she doesn't wake up from sleep to pass urine. Obviously, this frequency urgency during the waking hours and which is totally absent at night actually excludes a bladder pain syndrome, because in bladder pain syndrome, where the bladder is at fault, then it would be at fault even at night. It would not allow the patient to sleep. And next thing is to do a urine analysis. If the urine doesn't show any pus cells, nitrites, or leukocyte esterase, that means yes, this is the patient who may have bladder pain syndrome. The other investigations are ultrasonography and cystoscopy and biopsy. These are the mandatory parts of the protocol to treat these patients. In select cases, you should do a urine culture. For example, you have urine routine which is positive, you do a urine culture and treat it as infective cystitis in case you find something. And of course, if there are red blood cells, you should do a urine cytology. There could be small polyps in the trigone which could give rise to pain as well as microscopic hematuria. And if you can do, you should always try to do some kind of symptom scoring, because if you do a scoring, then it can help to the patient that when the person comes back after a month and you score her again, you realize that there is a difference in the score. So you can tell her that, look, last time your score was this time your score is this, which has improved. Then the patient also feels confident, and this works as a biofeedback to the patient that the drug is working, whatever treatment which is working. Urodynamic study is optional and is very scarcely needed in cases of bladder pain syndrome. So the urine analysis is the test for diagnosis of urinary infection. Culture only gives us the microbiological diagnosis. The diagnosis of UTI is made on presence of pus cells, nitrites, and leukocyte esterase. If any of these three is present, it is infective cystitis and not interstitial cystitis. So obviously we have talked about it. Then scoring system. So we have developed a scoring system which is similar to old Leary Stent score, but the difference is that we have added two domains, the sexual dysfunction and the psychological impact. And also, since pain is the most important factor in the whole disease process, we have amplified pain score by 4 times. So instead of 0 to 5, it is now 20. And the nocturia, which is another bothersome symptom, it has been amplified by 2, a factor of 2. So Apollo clinical score is now 0 to 50. It has been validated and has been also published. It as a validated score and has been used internationally in many centers. Recently, the Persian translation of this has been accepted for publication as a validated score for the use of for scoring of these patients of ICBPS. So this is the Apollo clinical score I was talking about. This has been validated in India. Now it has also been validated in Persian and Persil translation. So internationally, many places it is being used. Cystoscopy is not essential for diagnosis of ICBPS, but however, it is required to exclude serious uh, diseases. Therefore, it is important to do cystoscopy. It should not be done under local anesthesia. Imagine there is a bladder which, when distends, causes pain. So when you're doing cystoscopy, you are causing distension of bladder, and that causes pain. So it is important not to give pain to the patient. The other reason is once you are looking inside, you should do hydrodistension in patients with bladder pain syndrome. Hydrodistension is a treatment, and so is if you find some Hunner's lesion, you should be able to ablate Hunner's lesion. So if you are doing it under general anesthesia, in one go, you can make a diagnosis, phenotype it, and treat it. That is why you should be doing it under general anesthesia in one go. And there is a way to do the cystoscopy. So if you are missing the methodology, you will be missing the pathology on cystoscopy. So I will urge strongly that you should follow a disciplined way of doing cystoscopy in these patients. So when you do cystoscopy, either it would be normal or there could be non-specific bladder findings. like mucosal cracks, glomerations, or diffuse bleeding, or a small capacity bladder. And there could be a specific thing, which is Hunner's lesions. So Hunner's lesion is a circumscribed reddened mucosa with small vessels radiating towards the central scar. You can see it on the video, and there could be a small fibrin deposit or coagulum at the center. The point is that the rest of the bladder is absolutely normal. And if you see once, you will never miss a Hunner's lesion. But it is important to recognize this lesion because it has a different phenotype and a different pathophysiology, and therefore a different mode of treatment is required for this disease. So what we do is when we do cystoscopy, we classify these patients further. So definition is as per the Gibbs definition, you can make a diagnosis. If you make a diagnosis of bladder pain syndrome, you subject them to cystoscopy. Either you find a Hunner's lesion or you don't find a Hunner's lesion. If you find a Hunner's lesion, then you follow the treatment for Hunner's lesion. If there is no Hunner's lesion, then the bladder may be just normal. If the bladder is normal, then it can be termed as non-bladder centric bladder pain syndrome or hypersensitive bladder. But if the bladder is not normal, that means there could be glomerations, mucosal cracks, or bladder capacity less than 350 ml, then this becomes a bladder centric disease. So you have a bladder centric disease, and in those bladder centric disease is the one where we are going to use our new modality that I'm going to talk about. So why should there be a bladder-centric disease? Because there is damage to the gag layer of the bladder, which increases permeability, inflammation, and hypersensitivity of the bladder. There is a urothelial bladder. If you understand, there is a bag of tissue which contains urine with a pH of 5.5 or even 5, whereas on the other side of the barrier is the pH 7.4 of tissues and the blood. So there has to be a strong barrier where it does not allow the acid to get inside and burn the tissues. So what is that barrier? That barrier is the urothelium and transitional epithelium. So there are these cells which are umbrella cells which will hold the luminal tissues, luminal contents, which is urine, against the tissues. And these cells also secrete what is called GAG. GAG is glycosamine glycan layer. And this is how it looks like a fuzz-like coat on the electron microscope, that this is a fuzz-like coat. And that is the coating which prevents the acid in the lumen to hurt the bladder. And, it has if you look at it, it has a superficial layer and a deep layer. I'm not going to go into details, but it is that proteoglycan and the glycoproteins. It's a mixture of the proteins and glycans in various forms, which actually forms a thick gel-like layer. It is like insulation of the bladder from the acidic content of the urine. And this gag layer is a mucopolysaccharide coating which is produced from the umbrella cells. It's highly polar and it is hygroscopic. It is negatively charged, so it repels a lot of bad elements anyway because of being negatively charged. Now, what happens that if there is something that goes wrong, it causes, I'll just skip this. If there is denudation of gag layer, that means now if you look at it, the various components are chondroitin sulfate, hyaluronic acid, uroplakin, all these things. Suppose they get injured because there is something going wrong in the bladder mucosa or the transitional epithelium. So they will start hurting. Some kind of proteins are not being formed. The moment this happens, the urine, the toxins in the urine, which could be the acid, the potassium, which influx into the bladder, it causes injury and further depletes the various layers of the gag. This is important to understand. Once the gag is gone, the umbrella cells are also missing. So once the umbrella cells are missing, there is no further gag production, and the patient is now exposed to continuous injury of the urine into the bladder. So what should you do? So what you should do is, I will just come to replenishment. If it is, for example, if there is a hole in the insulation, you would try to put something to plug that hole. If you can plug that hole, you give the urothelium the opportunity to heal. And that is where exactly what we do by giving exogenous gag. So exogenous gag is actually a complement with proteoglycan, and it can fill any electrostatically empty area, and it can give a temporary coating which causes a reduction in inflammation, and it reduces the mast cell. It repairs the coating of urothelium. So imagine you have an injury on your skin, you have an abrasion or a cut. What do? You put something like a dressing on it. So that dressing, what it does is it allows the skin to heal without a secondary injury. This is precisely what we do when we are trying to give gag into the bladder. We are filling the gaps which have been created so that there is no further injury to the bladder. And that is where it is important that there are so many gag replenishment methodologies, and we are going to talk about one today. So FDA approved oral pentosan polysulfate in 1996 for approval of interstitial cystitis, and it replaces the gag layer of the bladder. Only thing is it has to be taken orally, and a small percentage of oral pentosan polysulfate reaches the bladder, and that plugs the holes in the gag layer of the bladder and allows the bladder to heal. But there are certain concerns lately which have come up with oral pentosan polysulfate. I do not know if they are true or not, but then there is a question mark that has been put. We are still using with caution, with a detailed discussion of the patient. But we would be very happy. And if you want to know more about oral pentosan polysulfate, here is an article that you can go back and read, or our uh, uh, team, Swati Spentos, is going to help you if you cannot find it. And then, since there are so many things, one, you have to take pentosan polysulfate 3 times a day, and then there was some challenge which has come up because somebody has started this, that there could be maculopathy after long-term use of pentosan, which might be true, but as of now, it is still controversial. And therefore, the newer thing that has come up is an intravesical solution of pentosan polysulfate. As I just mentioned, that there could be holes in the insulation and you need to plug those holes. So the best way would be to put in intravesically pentosan polysulfate, which has been approved by the Drug Controller General of India. And the product that has been approved is a 30 ml solution of pentosan polysulfate, almost 300, it is 300 milligrams in 30 ml, and it is in the form of a vial, and you should be able to use it directly into the bladder. If you do direct instillations, it targets the damaged urothelium instantly and promotes the gag layer restoration and healing. It reduces inflammation, and it's a potential for quicker symptom improvement because you're plugging the insulation holes immediately by putting pentosan polysulfate inside the bladder. So coming back to my patient, she underwent cystoscopy, found to have Hunner's lesion with hydrodistension and fulguration was done. We followed her with heparin hydrocortisone cocktail intravesically for 6 doses. That is what we have been doing for last 25 years, 30 years now. And oral pentosan polysulfate with mirabegron and urinary alkalizers, along with strict dietary control. And she improved significantly. and this Apollo clinical score fell from 46 to 18, but she returned after a year of recurrence of symptoms with ACS of 40, the score of 40. Again, she underwent cystoscopy, hydrodistension, had Hunner's lesion which were fulgurated, followed by another 6 weekly installations, and then she yet again returned. And this time after 9 months, we discussed the intravesical pentosan polysulfate, and we gave her 6 weekly installations. Her ACS has now become 24 from 42 and is well maintained. So we then had a small group study of safety and efficacy of intravesical pentosan polysulfate solution in bladder-centric ICBPS. It is important that we must select our patients. As I said, that we should have phenotyping. So you must find out in which patients this should be used, so that in those group, if in that group, if you use the pentosan polysulfate intravesical, it should give you result. Because if you keep on using it in all patients, you may not find as good result as you will find in a proper subgroup that you've identified after cystoscopy. So we had a kind of study on 18 on these patients where we picked up bladder-centric disease. Bladder-centric disease means anything which has Hunner's lesions or mucosal cracks or hemorrhages or glomerulations or the bladder capacity less than 350 ml. So obviously we excluded patients who had hypersensitivity and who had urinary tract infections. So cystoscopy was performed in the general anesthesia as per the paper that we just talked about. And we picked up our patients with bladder-centric disease. And there were 8 urologists in 4 different cities of India with 12 patients who collated their data. And what we did was we put the pentosan polysulfate inside the bladder as per the standard protocol, and twice weekly 30 ml for 8 weeks along with oral pentosan polysulfate, because we were scared initially to stop the oral pentosan. And during this study, we continued to give oral pentosan polysulfate. Nowadays, we don't give oral pentosan if we are giving intravesical. So obviously, pre-treatment concomitant medications like amitriptyline or hydroxyzine or urinary alkalizers were all continued, and the dietary modification which they were carrying on was advised to be continued. The methodology is very simple. We empty the bladder with infant feeding tube in the office itself and instill 5 ml of soda bicarb solution and wait for 2 minutes. And then we add 20 ml of lignocaine solution, 2% lignocaine solution, and wait for another 5 minutes. Then we drain it. And then once we have drained this solution, we instill 30 ml of Comfora Instill, which is 300 milligram of intravesical pentosan polysulfate, and remove the tube. We encourage the patients to hold on for at least 1 hour, if not more. And then some of the patients may have pain in that evening, and we tell them to take diclofenac sodium for the pain if it becomes too unbearable. And we warn them not to take spicy or citrus food items, at least on that day. And we use the clinical scoring system. And of course, this scoring system on day 0, that is before we start the treatment, and at 8 weeks. And of course, I've talked about the scoring system. We had 12 patients. There were 10 females. The mean age was 49, but the youngest was 26 and the oldest 75. And there was a significant improvement across all domains of Apollo clinical score in terms of, and it was well tolerated. And bladder seam pain was only aggravated on day of installation, and some patients only, not all needed diclofenac sodium 50 milligrams, and 2 patients reported mild GI upset. There were no dropouts. And if you look at the ACS scoring, so all the domains, there was a reduction in the points, and the mean reduction in the ACS, main ACS before treatment was 33, and after treatment it was 11.1. So the greatest improvement was seen in pain and nocturia. The pain score and the nocturia score had the maximum reduction from 8 to 2 and 16 to 4. And this is another way of representing the same data. And for the sake of discussion, we have that this is a targeted drug delivery with improved outcomes with local action and minimal systemic exposure. And, and we could see that there is an objective and subjective improvement as seen on the Apollo scores. And of course, we are using it in a well-defined patient phenotype. We don't use it with all the patients, and it is well tolerated with very favorable safety profile. But of course, the maintenance therapy strategy is still multimodal. That means we keep giving the other things like dietary modification, the exercise, and the symptomatic relief in the form of hydroxyzine or amitriptyline. Of course, this is a small population with short follow-up, and we don't know when we are using three drugs with urinary alkalizer and lignocaine. Maybe they have a direct effect on pain, but whatever it is, in addition to this, when we are giving pentosan polysulfate, there is a very good improvement in the pain and nocturia frequency, nocturnal frequency. So in conclusion, intravesical pentosan in conjunction with oral pentosan and non-specific medication in this particular group gives a very good symptom recovery. It is important, but nowadays I am not using oral pentosan for these patients because we have started a small study in our own department, and we are trying to see whether we should be giving only intravesical or we have to carry on with oral. So we are just still learning and evolving. This intravesical pentosan has a role also beyond ICBPS. For example, patients with recurrent UTIs. The pathophysiology is same. There is a damaged ganglia. While you are giving antibiotic and while you are working on these patients, if you give pentosan polysulfate, then it encourages healing within the bladder. But of course, you should not uh, depend solely on the intravesical pentosan, and if there are compounding factors, they must be looked at. For example, large residual urinase or vaginal dysbiosis or reduced local defense in the form of atrophic vaginitis and urethritis, or in patients who have chemotherapy, there the the defense is already lowered. So you have to carry on with all the treatments, and in addition, you can use intravesical pentosan polysulfate. It takes almost 3 months for the ganglia to replenish completely to obviate the symptoms. Therefore, don't be in a hurry. It can also be used for chronic infective etiologies like tuberculosis cystitis, and more important, for urologists who are dealing with bladder cancer, where we give intravesical BCG. So BCG-induced cystitis can cause really bad symptoms. So these are the patients in whom you can give pentosan polysulfate. Of course, in radiation cystitis, there is injury to the bladder. The symptoms are more or less same. There's frequency, pain, urgency. But this is the time, it is the early radiation cystitis where you should give pentosan polysulfate. When it starts bleeding, we have all seen bleeding radiation cystitis with bleeding with clots, hematuria. Those are the patients in whom you should refrain from using pentosan polysulfate and wait till the bleeding can be controlled. Once it is controlled, you can start radiation, you can start intravesical or oral pentosan polysulfate. Thank you very much, and I hope this has been taken well and you have understood few of the points that I wanted to make.
Uh,
Over to you, Dheera.
Yes, sir. Thank you so much, sir. Thank you for this very comprehensive and yet a very thorough light on the subject. We are happy to take any questions. So if anybody has any questions, you can please put it out in the Q&A chat box. Sir, would you be okay to answer? We have a couple of questions which have come. Could I read them out to you, sir?
Yes, of course.
We have one question. The person asked, how is heparin hydrocortisone given and at what dose and what preparation would you give it, sir?
So that I've been using for more than 2 decades, and it is just uh, heparin, which is 25,000 international unit. It is a 5 ml vial, and you have hydrocortisone, which is 200 milligrams, 100 milligrams into two, so 2 vials in normal saline, and make a solution of 40 ml and instill in the bladder with a small infant feeding tube, and that works very well. So you ask the patient to hold on. It's just 25,000 international units of heparin and 200 milligrams of hydrocortisone in 40 ml saline.
Sir, if I may add to this question from my side, I have read that there are various bladder cocktail regimens that have been listed, and most of them carry at least 4 to 5 drugs. But I see the regimen that you follow is just with hydrocort and heparin, which is 2 drugs. So, is there any particular reason for this? Like, have you seen better outcomes or any trials which you have seen with it, sir?
So I started with 4 drugs, and I realized that when you put all the drugs, there is an in vitro, drug-drug interaction. It becomes cloudy. And I realized that the active ingredients were only the heparin that I needed, and of course the steroid which was needed to reduce the inflammation. And that's why I just kept using these two. And I have never means I have had wonderful patients on this cocktail itself, just the two of them. And for the last more than 20 years, I've been using this. So I initially, when, as you rightly mentioned, there are people who would use 4, but I realized that if you put them all together in a syringe, I do not know what was getting denatured. So with heparin is a very sensitive molecule. So if you are killing it inside the syringe itself, then perhaps it would be not scientific to use it.
Okay, noted, sir. So we have a question. Is it necessary to give intravesical lignocaine and soda bicarb? That is before the pentosan polysulfate. If it is given, why do we drain it? Why
Yes,
not just add pentosan polysulfate to the mixture?
I will tell you the story. The problem is that intravesical pentosan can be very painful. So you have to anesthetize the bladder. The role is to anesthetize the bladder. So how do you anesthetize the bladder? By putting intravesical lignocaine. So the problem with that is that lignocaine is rapidly, destroyed by the acidic pH. Urine contains acidic pH. So first step is to neutralize the acid. So that is why the first thing that goes in is a soda bicarb. You wait for 2 minutes. You allow the pH to turn alkaline. That is when you put the lignocaine. Wait for 5 minutes. Now this is the time when lignocaine has acted inside the mucosa and it has blunted the pain fibers. And then you put pentosan polysulfate. Despite all that, patient will complain of pain after the lignocaine effect is waned off. I mean, maybe 4 or 5 hours later, they come back with pain because if there are holes in the gag layer and the pentosan has gone there and stuck there, pentosan is actually, it can cause pain. So itself to begin with. That is the reason we need to first anesthetize the bladder. And to anesthetize the bladder, we have to alkalinize it and then give lignocaine and then remove it. As I said, why to remove it? Because we don't want anything between the bladder and the pentosan polysulfate that we are going to put.
Right. Thank you, sir. So we have further questions from another doctor. They ask, how long should the patients take pentosan polysulfate, and could you throw more light about the maculopathy incidence with the molecule? That would
Yes.
be of oral, with oral, I'm sure that's what.
Yeah. So initial reports that started coming were almost 5 years ago, where people started recognizing a kind of maculopathy in patients who have received Pentosan. And incidentally, these patients, maybe three patients, the ophthalmologists found that they were taking Pentosan polysulfate for more than 12, 13 years. So that was the thing, and it was found in United States. So they linked the long-term use of oral Pentosan polysulfate to maculopathy. Now, more data was started to emerge, and now there was a paper in 2024 from Canada which mentions that this maculopathy is incidental, and is incidental because it is the same disease process what is happening in the bladder. Because in the bladder also there is basically a vasculopathy. If you look at Hunner's lesion, it is a vasculopathy. So it is the same vasculopathy which is also being seen in the retina. So maybe that is related. But as I said, we are still evolving on it. There is no final word. Whatever it is, the current evidence is that there is a possibility of maculopathy in long-term use, and we must tell the patient before we prescribe, before they accept the treatment, that there are certain reports, but they are all beyond certain years. So we start with that oral pentosan polysulfate. And by and large, if it is a non-Hunner's lesion, and if you are treating the rest of the etiological factors that you may come across, as in phenotype, etiopathogenesis based phenotyping, then perhaps you can withdraw oral. Many of my patients are off oral pentosan because they have healed well. So it is not that we have to give them for years together, but yes, we have to identify the pathophysiology, and that is how we will be able to reduce or take them off oral pentosan.
Right. So our next question is, as you put it out, the other indications of using the Comfora Instill, the Pentosan Polysulfate Instill. So a doctor wants to know that would you use it for postmenopausal chronic recurrent UTI? Are you currently using it, sir?
Yeah, so as I said, you have to deal with those factors. So if there is a postmenopausal chronic UTI, obviously there is a problem with the defense. So you give estrogen local application. There is a problem with the dysbiosis of the gut. There is problem with dysbiosis of the vagina. And that is what we'll keep doing, will keep causing recurrent UTIs. The problem, how Pentosan helps is that it will help the bladder symptoms. It will not treat the UTI. And the UTI, the bladder symptoms are result of assault by the UTI. So unless you stop the assault by the UTI, the bladder symptoms will continue to be happening. So if you stop the assault of UTI by treating UTI properly and add pentosan polysulfate, then the patient's outcome becomes much better. Patient recovery becomes much faster. The bladder symptoms improve rapidly, more rapidly than you expect only with antimicrobials.
Sir, if I may add to this question, if someone is having an active UTI, do before putting pentosan polysulfate instill, does the UTI have to be treated completely, or
Yes,
I?
yes, UTI must be treated. You must have a sterile culture before you put in a tube into the bladder. So you take that window, you have killed the microbe, but the bladder hasn't healed yet. So this is the time to give pentosan.
If I may add another, so would you do a urine routine before every instill?
Not really,
No.
because we have made a diagnosis
Okay.
unless there is a reason to suspect. If the patient comes back and says that I've been having flare up of symptoms in the last 2 days, then we must do a urine routine to make sure that she's not infected before I put the next catheter.
So our next question is in regards to the use of tacrolimus. So do you inject tacrolimus for the Hunner's lesion?
See, local tacrolimus has no logic because tacrolimus works by immune modulation. So immune modulation. So if you look at Hunner's lesion, it is a systemic disease. So you need to treat it systemically. So if you have to use tacrolimus, you have to give systematically, orally or whatever systemically, so that all the T cells or which are involved in the production of or generation of Hunner's lesion are affected. So you cannot treat Hunner's lesion with local tacrolimus. You can use local steroids to combat inflammation, but tacrolimus is not a steroid. It modulates T cells. So how do you propose to modulate T cells by intravesical treatment? So it has to be a systemic treatment. So I'm really very skeptical that how somebody can think of using tacrolimus in Hunner's lesion intravesically.
That's well noted, sir. So we have a question whether you're using cocktail therapy and how are you using Comfora Instill? Uh,
Yeah, so
so
I
it,
have two arms in my unit, and two residents are doing two different theses. So these are obviously when we do cystoscopy, we phenotype them into Hunner's lesions and non-Hunner's bladder centric. So Hunner's lesion go for oral tacrolimus and non-Hunner's go for intravesical treatment. So I was using cocktail therapy till very recently. But the new resident who has joined me, I have given him a thesis for Comfora Instill, which means that if there is a non-bladder centric, which means that there is a bladder centric non-Hunner's lesion, then we will give intravesical Instill, intravesical Comfora. So I have three patients as of now. We just started this project, which is slightly different from the one that I projected on my screen. But we are using intravesical Comfora for non-Hunner's bladder centric disease now.
can we give it even in patients who we see Hunner's lesions, or you would
Yes.
specifically keep it for
Yes.
patients without Hunner's lesions?
No, no, it is because in my unit we are enrolling Hunner's lesion for oral tacrolimus. So those patients who do not consent for tacrolimus, because we give a detailed discussion, we have a detailed evaluation before we start tacrolimus. The patient goes through a physician, a nephrologist actually, and then it is actually a part of the project. Otherwise, you cannot prescribe tacrolimus like this. And for that project, we have sanction from the DCGI. The DCGI knows that we are using tacrolimus for Hunner's lesion. So it is not a very casual approach. So if the patient has a choice to refuse tacrolimus, because there are so many friendly advices, many of the families have a lot of doctors who will scare them for tacrolimus, so they will not take tacrolimus that way. And those patients who refuse tacrolimus, we put them either with intravesical, because as I said, bladder centric disease. So primarily it is non-Hunner's bladder centric, but if there is a Hunner's lesion, bladder Hunner's lesion also bladder centric. So those patients also we give intravesical pentosan now, because we are enrolling for intravesical pentosan now.
Thank you, sir. I think we have covered all the. We have a question now, which is what's the regimen for Comfora? Uh, I, I do know that sir had thrown light on this in his talk. So would you want to give it in a comprehensive, comprehensively, sir?
So the question is, what is the regimen?
Regimen, yes, sir, that you
So
would
as I
follow.
said, so if you're talking about oral Comfora or Comfora Instill, so Comfora Instill is twice a week for 8 weeks. Comfora oral is 3 times a day, 100 milligram capsule to be taken 2 hours before meals or 2 hours after meals. It should not be taken with meals because the bioavailability is affected. And it should be continued for at least 6 months, 3 to 6 months before the visible effects of oral pentosan polysulfate are seen in patients with bladder-centric disease.
Yes, sir. Thank you. We have covered all the questions. So if we can put it all in a nutshell, if I could ask you, uh, if a patient comes to me in the OPD, and what would your approach be if I have the suspicion of a bladder pain syndrome or IC, having ruled out the other causes? for
See,
all practical purposes, sir.
so if you listen to the patient, patient tells you the story. So if there is pain associated with urinary cycle, micturition cycle, if the pain is starts when the patient starts passing urine, so this is urethritis. If the pain starts towards the end of urination and stays for some time, then this could be vaginitis because the urinary acid is hurting the vagina and it is staying for some time. If the pain is relieved on passing urine, then obviously this is bladder pain syndrome because pain is because the bladder is distended. If the bladder is de-distended, that is, it is being evacuated, the pain will reduce. So, having said that, if your urine routine is silent and does not indicate an infection, you must do a cystoscopy and look inside the way that our methodology, Gibbs methodology is, so that you measure the bladder capacity, you inspect all corners, it is done under anesthesia, and you find some bladder centric disease. For example, if there's a small bladder, then you distend it, and then you, if there are glomerations or if there are cracks, you notice them, and then you classify them. Basically, cystoscopy is also important to classify these patients. That is called the phenotyping. So that is how you should proceed. And I've given an algorithm that we have developed where we can categorically say this is the patient who fits into this category, so use this treatment.
Thank you so much, sir. There's a saying that I remember: I can't do better if I don't know better. I know that by the end of this session, that all of us will be able to do better because we all know better now. Thank you once again, sir, for sharing your years of experience along with combined with the latest development in the treatment options. Sir, any closing remark from your side?
Yeah, the closing remark after this talk, I want to say that you, when you go back after this webinar, don't think that every bladder pain is bladder pain syndrome. That's the biggest thing that I see, because if you have a hammer, I have given you a hammer, everything looks like a nail. So I see so many patients who come to us who are actually infective cystitis, and they are being treated as interstitial cystitis because there are pus cells. But if there are pus cells and the urine culture is sterile, people think this is bladder pain syndrome. No, urine culture is not the way to diagnose. It is the urine routine which makes the diagnosis. So just look at urine routine and then decide whether it is infective or non-infective bladder pain.
Yes,
Thank you
sir.
very
Thank
much.
you. Thank you
Thank you
so
very
much,
much.
sir.
Thank
Uh,
you so much for this wonderful show, and thank you, Swati, Ashwani Patil, and Swarangi Patil to be there representing the Swati Spentos Limited, and for this wonderful Health Bridge initiative. I'm sure a lot of people would have been helped. And if there are any more queries, I would be available on email, and you can find feedback from them, and they will tell you more about it. Thank you.
Thank you, sir. Over to Ashwini.
Yes. Thank you, Dr. Taneja. Thank you, Dr. Dheera, for such an insightful and enriching session. And thank you to all our doctors for being part of Swati Health Bridge. See you soon in our next session of Swati Health Bridge, continuing clinical conversations with matters. Thank you, everyone. Thank you all.